Survodutide may change more than the number on the scale. In a Phase 3 obesity trial, 6 milligrams reduced weight 13%. Magnetic resonance imaging showed 34% less visceral fat and 63.1% less liver fat. That matters because two people can lose the same 13% and still experience different health changes. Survodutide's standout signal is where fat was lost, especially around organs and inside the liver. Survodutide is a weekly injection still being studied that activates two hormone signals. One signal reduces appetite and slows stomach emptying through glucagon-like peptide 1. The other is glucagon, which acts in the liver and can increase fat burning and energy use. Researchers therefore tracked fat distribution as well as body weight. The obesity trial included 725 adults without diabetes and lasted 76 weeks. Participants received 3.6 milligrams, 6 milligrams, or placebo, an inactive injection, with diet and exercise counseling. Average weight loss was 12.2%, 13%, and 5.4% respectively in the main analysis. That main analysis counted stopping treatment early, using other weight loss drugs the study did not allow, or delaying the planned dose increase. Another analysis estimated outcomes if participants stayed on treatment as planned. Under that approach, average weight loss reached 16.6% with 6 milligrams. The two analyses answer different practical questions. A planned imaging study within the trial examined which tissues were lost. With 6 milligrams, total fat volume fell about 28%. Visceral fat fell 34%, and liver fat fell 63.1%. Lean tissue, meaning non-fat tissue, fell 9.8%. Only 10.8% of all tissue volume lost was lean tissue. This pattern strongly favored fat loss over lean tissue loss. Lean tissue is more than muscle. It also includes organs, body water, and other non-fat tissues. The imaging suggests that most lost tissue was fat. Because the scan did not measure muscle alone or strength testing remains important when judging the quality of weight loss. Visceral fat sits deep inside the abdomen around the organs. Fat beneath the skin is called subcutaneous fat. Higher visceral fat is linked with insulin working less effectively, abnormal blood fat levels, and higher heart and blood vessel risk. Losing visceral fat can therefore matter even when two people lose the same weight. Liver fat is another risk that body weight cannot reveal. Excess liver fat can cause fatty liver disease linked to metabolic problems. Some people develop liver inflammation, cell injury, scarring, and eventually advanced scarring called cirrhosis. A Phase 3 trial studied adults with obesity and fatty liver at higher risk of liver damage. The trial assigned 218 participants by chance, and 216 received survodutide or placebo. Some had tests suggesting liver inflammation or scarring. Others had a liver tissue sample showing severe fatty liver with inflammation and injury. Participants received 6 milligrams of survodutide or placebo for 48 weeks with lifestyle counseling. In an analysis that assumed people stayed on treatment, 84.2% on survodutide reduced liver fat by at least 30%. Only 24.3% on placebo reached that target. The main analysis produced lower percentages because it included people who stopped treatment. At least a 30% liver fat reduction occurred in 68.5% on survodutide and 28.6% on placebo. Average weight loss was 8.7% and 1.4%, compared with 12.2% and 1% in the analysis that assumed continued treatment. Those results show why trial percentages need context about how they were calculated. One analysis estimates results during continued treatment. The main analysis also counts people who stop treatment. Mixing those numbers can create misleading comparisons between studies. A liver fat reduction of at least 30% matters because it is linked with a better chance of improving liver inflammation. In this trial, 61% on survodutide reduced liver fat below 5%, compared with 5.7% on placebo. Liver volume, waist size, and several liver-related blood tests also improved. That adds context beyond body weight alone. An earlier Phase 2 analysis found that some liver-related improvements were greater than weight loss alone would predict. Researchers could not tell whether glucagon or another effect of the drug caused the difference. In that analysis, weight loss did not fully explain those liver improvements. Consider two patients who each lose 13% of body weight. One develops a smaller waist, less liver fat, and better liver tests. The other keeps substantial liver fat and loses more strength. Their scales look identical, while their health risks and physical function move in different directions. The imaging results are not enough to rank survodutide above Wegovy or Zepbound. The obesity trial compared survodutide with placebo, not with semaglutide or tirzepatide. Separate trials also differ in participants, treatment duration, dropout rates, diabetes status, and analysis methods. A direct comparison trial is the proper way to rank them. Even attractive fat loss results matter less if patients cannot stay on treatment. Nausea, diarrhea, vomiting, and other stomach and bowel symptoms were common while doses were being increased. In the obesity trial, these symptoms affected about 81% of the 3.6 mg group, 90% of the 6 mg group, and 48% of placebo participants. About 19% of participants receiving survodutide stopped treatment because of stomach and bowel side effects, versus about 3% with placebo. Interrupting treatment reduces the chance of reaching the weight and liver fat results seen in the trial. A dose that can be continued may be more useful than a higher dose that is repeatedly stopped. If survodutide is approved, treatment choice should match the patient's main risk. Severe obesity may make total weight reduction the priority. Substantial fatty liver may shift attention toward liver fat reduction. Repeated vomiting or physical weakness may make side effects, nutrition, and keeping strength more important. That makes survodutide especially interesting for obesity, accompanied by substantial liver fat or visceral fat. Doctors would still need to review liver damage, current medications, previous side effects, nutrition, strength, and the dose a patient can handle. The best candidate is someone likely to stay on treatment safely enough to benefit. Patients focused mainly on scale weight loss may care less about survodutide's liver fat results. Previous severe vomiting on similar drugs also matters because stomach and bowel side effects were common here. People who already have little muscle deserve particular attention, since lean tissue still declined during treatment. For now, those candidate discussions are hypothetical, because survodutide is not an approved prescription medication for weight loss. Products sold online for research use may lack the manufacturing and quality controls used in clinical trials. Their ingredients and doses may be uncertain, and sterility or contamination can also be a concern. Because survodutide is still being studied, trials must determine whether it reduces liver failure, heart attack, stroke, or other major events. Longer follow-up must show whether improvements last for years. Imaging changes become more valuable if they translate into better health, function, and survival. If survodutide is approved, follow-up should extend beyond body weight. Waist circumference, liver blood tests, blood sugar, and blood fat levels can show whether the body is handling sugar and fats better. Liver imaging can help when fatty liver is a major concern. Strength and activity also show whether physical function is preserved. These measures show whether weight loss is improving health. Survodutide's real advantage may be where fat is lost, not simply the total weight lost. The strongest current signal is substantial loss of visceral and liver fat alongside overall weight loss. If approved, the clearest candidates are patients with substantial liver or visceral fat who can tolerate treatment consistently. Medicine simplified. That's what this channel does. If you want more, hit subscribe. This is not medical advice. Consult your doctor.